Hi, I'm Jackie Thelian, and welcome to Key Coding Tips. Today we're going to talk about some of the pitfalls of using the EMR. Some of the topics we want to touch upon are listed on today's agenda. The implementation of electronic health records brought about many changes which improved clinical documentation and many changes which have a negative effect on the auditing process. Today we're going to take a look at some of those pitfalls. There are some very basic documentation requirements, many of which have been significantly improved with the implementation of the electronic health record. For example, legibility. It's wonderful to see that all the notes are now legible. What CMS and insurance carriers and auditors are beginning to notice is that many of the notes go beyond a relevant history for the patient's visit. In many cases, the patient's entire history is carried over from either their initial visit or previous visit, much of which has absolutely no relevance to the encounter or the visit for that day. Medical necessity for ordering of tests still remains an issue with the EMR. It's important to note that rule out does not constitute a valid reason for ordering a test. In these cases, you would report the signs and symptoms that prompted the request for the test. The patient's responses and changes to treatment and revision of diagnosis is extremely important, since this helps to provide medical necessity for the visit. In many cases, with the implementation of the EMR, all of the patient's diagnosis codes are carried over in each note, including diagnosis codes that have not been evaluated since the patient first came in. This brings us to the issue of clone documentation. So this slide gives you the description, or the definition rather, of what CMS considers to be clone documentation. It's important to note that the cloning of documentation is considered a misrepresentation of the medical necessity requirement for the coverage of services. In which case, identification of this type of documentation will lead to the denial of services for lack of medical necessity. This allows the carriers to recoup money for those particular services. Cutting and pasting can also lead to requests for overpayments. And there are a number of issues we have when we see cutting and pasting. It usually ends up with conflicting information within the note itself. For example, the patient could come in complaining of shortness of breath, chest pain, abdominal pain, and we see this listed in the history of the presenting illness. Then we move on to look at the review of systems, and everything is negative or the patient denies it. So in this case, you now have conflicting information, in which case the review of systems would be discounted from the auditor or the reviewer. It also begins to put into question the integrity of the data itself. Cutting and pasting may also result in bringing over outdated information. In a number of cases, the information is carried over without ever having had been updated. It's important to note that each time you bring over conflicting or outdated information, you're adopting this information as your own. And therefore, even if it was information from your colleague and you're bringing it over in your own note, you now become responsible for those conclusions. Clickitis is another issue. Actually, this phrase was coined by one of the physicians that I worked with, and it speaks to anyone or physicians who are just clicking through complete physical exams or clicking through bringing over information. So you need to be aware of what it is you're clicking and what's actually coming over into that note. The volume of documentation, I can tell you personally from an auditing perspective, CMS hangs its hat on the Social Security Act in denying many, many claims, which speaks to the volume of the documentation. With the implementation of the electronic health record, we're seeing more notes that are 7-10 pages long. But yet really, what is the meat and potatoes? What's relevant to that encounter for that patient for that day? So in these cases, the medical reasonable and necessity standard will be the overarching criterion for the payment of all services billed to Medicare. And this actually comes right out of the Medicare Internet-only manual, so it's important information not only to read, but to understand. What this is basically stating is that even if you document a comprehensive history and comprehensive physical exam, If there was no medical necessity to do so, only that which is relevant to the patient's encounter for that day will be considered. For example, it's very easy to cut and paste or click through a comprehensive history and comprehensive physical examination. But if the medical decision indicates the patient is stable and came in for a prescription refill, the encounter will not be considered to be a level 5 or 99215 visit. So in this case, even though you documented a comprehensive H&P, the documentation guidelines for an established patient say that you need 2 of those 3 key components, which indeed you have with the history and physical. It will still be only the medical decision or the medical necessity for that particular encounter which will determine the level of service. In this case, if the patient is stable and just presented for their prescription refill, it would be a much lower level of service. Diagnosis linkage, we've had this problem with paper records. We also still see this coming through with the electronic health record. And again, this is where CMS offers us guidance. It's another problematic area. Simply checking off a diagnosis code, which is listed as providing medical necessity on the local coverage determination listing, without the patient having either the complaint or positive findings on the physical exam that would give you medical necessity, does not prove medical necessity for the test. Additionally, you need to remember, and this is most important, there are no rule-outs. In the outpatient setting, I want to be clear about that. In the outpatient setting, you cannot use a rule-out diagnosis to order a test. It does not provide medical necessity. In those cases, what you need to do is to document those signs and symptoms of that illness or injury in order to order that particular test. Timeliness is another problem that we see with the implementation of the electronic health record. Again, we have guidance from CMS, which are listed on these slides here. And when we had paper notes, you would sign off your note right after you finished writing it. In many cases, notes are either left open indefinitely or for long periods of time in the electronic health record. In cases where notes are completed days or weeks after the patient has been seen, again, this starts to bring into question the integrity of the data. For example, is that note being written by memory a week later after you've seen maybe 50, 60, 70 patients in between? Or is that note being written because you have some scratch notes or a holder note? If that's the case, that scratch note or holder note, whatever information you wrote on that patient, is actually a legal document and needs to be scanned into the electronic health record so the auditor can see where you received your information from. In any event, the note should be documented and signed timely. So CMS tells us that delayed entries within a reasonable time frame, which they consider to be 24 to 48 hours, are acceptable for purposes of clarification, error correction, the addition of information not initially available, and unusual circumstances. Leaving your electronic note open for long periods of time actually causes a number of problems. If someone were coming to order the note and that note is left open or unsigned, it is not a billable service. We need to have that note authenticated by the author. With the implementation of EMR comes electronic signatures. And with electronic signatures, of course, CMS has their comments. And they give us guidance as to what constitutes a valid electronic signature. So you can take this information and check with your vendor, your software vendor, to be sure that you meet those particular requirements. You also want to check with your MAC, your Medicare Administrator Contractor. Although CMS has issued guidance on a national level, some of the MACs have also published their own guidelines at the local level. These next 2 slides are the guidance provided from CMS as to what they consider to be a valid electronic signature. Okay, on this slide we can see a valid example of an electronic signature, and we also see digital signatures. With regards to a digital signature, these are usually utilized by radiologists as their signature is digitally appended after they provide the read for the study. The software vendors are able to provide proof that the signature is encrypted, safe, and secure. Having your system prompt you to the level of service can also be a potential recipe for disaster. In an audit situation, it comes down to medical necessity for the visit and not the volume of documentation. So in cases where your computer is selecting the level of service based upon the history and physical exam, keep in mind it will come down to the medical necessity, and therefore the computer selection may not always be correct. In an auditing situation, telling the administrative law judge the computer did it, not me, will not help you. You are the one who is responsible for the services that are ultimately billed. Another issue is where your system can prompt you that you need one more review of systems or one more physical examination body area, prompting you to potentially upcode that encounter. So having the system prompt you to add additional information in order to reach a higher level of service is also unacceptable. Remember, CMS and the insurance carriers will only count what is relevant for that visit. So adding information that's not relevant to that patient's encounter is not going to help you either. So how are these EMR audits conducted? You know, it's very different now. When we were looking at paper charts, we would just look at the chart itself, what was written. We'd go back, we'd look at any laboratory diagnostics. But now with the electronic health record, we actually have to go a little bit behind the scenes, much like detectives. If we right-click anywhere on that progress note, it opens up who documented what. It gives you the whole history of what went on behind that encounter. Who was documenting various aspects of that encounter, what time it was documented. So if you look at this, okay, it allows us to determine what to give credit for. It allows us to check time on time-based encounters, and it also allows us to determine impossible billing days. Know the rules. You need to know who is allowed to document what in that electronic health record. For example, the review of systems, past family and social history may be recorded by ancillary staff as per the documentation guidelines. However, the history of the presenting illness needs to be documented by the provider of service. So we can now actually go behind the scenes within that note to see who documented that HPI. Who is watching? You have a lot of eyes on you, particularly with the electronic health records now, with the cloning, which is actually on the Office of Inspector General's work plan and has been for the past few years. So in today's healthcare environment, CMS, the Office of Inspector General, and insurance carriers are aggressively auditing the providers. The next few slides give you some websites where you can go to learn more about it. This one references the Office of Inspector General's website where you can actually download their work plan. It usually comes out the end of October, beginning of November, and it's a great source document. It alerts you to what the Office of Inspector General will be looking at in the upcoming year. This slide here talks about the documentation guidelines, whether you use the 1995 or 1997 documentation guidelines. The only difference being the 1997 are specialty specific and the 1995 are body area organ system when it comes to how we document our physical examinations. This is the link where you can go to and download those documentation guidelines. You can choose either the 95 or 97. What I recommend is download both, and you can compare them to how your particular physician is documenting their medical record. If you have any additional questions or comments regarding the EMR pitfalls, please indicate them in the comments section below. Remember to stay updated and subscribe to Key Coding Tips. Thank you for watching.